Well, good morning, ladies and gentlemen. I am the second boy who is going to speak in English for the first time, so please mercy for this poor speaker. Thank you. I want to say thank you to She's Juan, and especially to Mario Bitbol from She's Juan Argentina. Gracias, Mario. And thank you for She's Juan Hungarian for your hospitality and for this beautiful city. Not Salom, it says. I work in the Ministry of Public Health in Argentina. I am the executive coordinator from Remediar. So here we go. Just a few words in order to put Remediar in context for you. We live in a mid-income country in South America with a high consumption of drugs. 63% of people, almost 28 million of population, consume medicine every month. And around 50% of our health costs go to medicines. So we have a problem with medicine, a rational use problem, and a problem with social equity too. Argentina is a republic, has a federal division of power. In this order, public health care is a provincial responsibility. It means that each one of the 24 provinces defines their own organization. Their federal governments, and when I work, define federal rules, implement a toolkit of policy, and provide by finance some health service in order to achieve equity in our development. Assure access to medicine is one of these national policy and the reason of the resistance of Remediar. Almost 59 million patients visit to physicians every year in the public primary healthcare providers and similar amount in hospitals too. So there are maybe 100 million people. I include here neither social security nor private sector because there is subsistence drug delivery is done through community pharmacies. The green points here represent this primary healthcare provider all around the country. Around 16 million people use it. Only at primary level, 38 million prescriptions are produced, which is 3.2 million on average every month. There are 5,000 kilometers, or 3,100 miles for you, from Ushuaia in the end of the world to La Quiaca near Bolivia. It's like 30 times Hungary and 5.5 times Spain. Compared with other Latin American countries, my country has an important pharmaceutical industry with more than 250 pharmaceutical manufacturers. It's 1% of the global market and takes up the fourth place in Latin American markets. As it was presented here many times, the ANMAT, or federal agency, regulated pharmaceutical activities. To record the batch numbers in all the commercial documents among stakeholder and public provider is required, but in 2011, a track and trace system was approved. This allows to establish and record the way followed by particular drugs from its manufacturer to its final destination, which is typically the dispensal point. It consists of using a unique and an ambiguous code placed in the packaging of each retail unit of the pharmaceutical product, which is transmitted to a centralized database managed by ANMAT. Each agents involved in the supply chain must record logistical movement of drugs, transmit their information to the database on a real-time basis. So how Remediar works in this context? We have 4 phases. We select, we procure, we distribute, and we use. First of all, we select 2 kinds of drugs from the WHO, the World Health Organization Essential Medicine list. One list for primary care in public context. There are 79 essential items included in this list. And the other list is defined by vertical problems. So these work out by priority healthcare lines, for instance, AIDS or TB control, so on. This is a view of our operation with drugs in terms of tracking system. the amount of items was incremented 4 times between 2002 and 2010, for almost 40 to almost 200 items. And 49.8 units are received for suppliers. We trace all secondary package. In 2011, started new tracking regulation, so nowadays 74 items require tracking by serial code number. Just a few important characters to remark in this point. We use international common denomination and rational use criteria. We define the packaging, as you could see in the slide before, and this is mandatory for suppliers. So in order to support this process, we elaborate in collaboration with One Argentina a guide to identify products, and it was incorporated into the bidding process. And also we elaborate an arts and style manuals in order to standardize the packaging designs and incorporate to the bidding process too. We use sheet-ins codes to define secondary packages to optimize inventory management, and we started negotiation for the purpose of incorporating electronic data interchange too. Here you have the labels and data carriers required. These are available on our website, you can see it. We use data matrix as a data carrier. The code has associated information. Apart from sheet-in, we have batch, date of expiration, serial number when required, and an internal Remediar code with an 19 code for this one. And also human readable information is included in the printable label. This is our core process, selection process. So you can say we receive, we stock up, we produce, and deliver. We receive products from pharmaceutical manufacturers in pallets. Pallets are composed by unique code and unique batch. As you can see in the picture, in last year, 49 million of secondary units have been received. All units are traced, obviously, but the point to remark here is that 6.4 million were traced by a serial number, so by a unique code. Then we compose or produce almost 30,000 multi-pallet, multi-product, multi-batch kits, like pharma-box-like, using serial shipment container code to identify these boxes. We deliver it boxes directly to healthcare provider and 93 local warehouse. This point are identified using global location number. An evaluation was conducted using SHIS-1 Global Traceability Conformance Healthcare, SHIT-DSH. The baseline was 32% in 2012, and here are the main results. We increased compliance to 94% in 2014, and we achieved all mandatory items. You can see she has one certificate over there. In addition, we incorporated scan technology and improved our information system for the management of supply chain. In the picture, there are both the kits and an associated document with a serial shipping container code and a barcode as a data carrier. So the ongoing is working with key performance indicator. We have our own indicator, but just to organize them in order to be more clear for suppliers, especially for pharmaceutical companies. And in the picture, you can see a pile. This is available in our website too. It's public information. And in the last phase, or utilization phase, which we can see our main outputs, one of 2 ambulatory patients received a prescription in primary care. 88% obtained here or hers medicine for free. That's the point. This is for free for people in your country. 2,000 doctors were trained in a rational use training program to improve rational use. 20 million of prescriptions were registered in paper support in 2014, but this year we incorporate to 1,200 healthcare providers were equipped with a computer and an optical capture device. So the ongoing change involve patient compliance and promotion of rational consumption. This is an example. In this order, a software, the electronic recorder of the dispenser was developed. The software allows to scanning identification standard, both for drugs and for persons, using our national ID. We catch it in a little seconds. And obviously, as you can imagine, the software allows you to define alert systems, for instance, for chronic people, for women with contraceptive, for refiles, etc., etc. And last but not the least, we produce training material for the health team in order to support the process and provide useful information to the community. Sorry. Come back. So management of drug supply chain in the public sector requires strong partnership with the private sector for a natural division of works, if you can imagine. And the use of a standard and also the use of quality certified process play a critical role to strengthen these relationships. For both public and private operators, compliance with regulation designed to ensure the legality of transaction in the supply chain seems to be possible. I hope you see it. And it's necessary to invest in technology and training at local level, healthcare providers, for instance, to ensure proper dispensation, because this allows patients safely develop an awareness system, monitoring, identification of drug interaction, cost reduction, etc., etc. Thank you, and I hope you visit that. We live in a nice country. I done it. My mother will be proud of me.
Very well done. Thank you very much. And if there are questions, Mario is here and can help with any translation, my colleague from GS1 Argentina. I think you can also see Argentina is a country which has regulations in place for drugs and medical devices and has really progressed very well with implementation. And they have mandated always down to the hospital. So everybody needs to implement the whole supply chain. So with really great results. So with that, I come to the last speakers before the lunch. These are my colleague from GS1 Slovakia, Mariana. And she has brought with her the CFO of Dovera, which is a health insurance. And I think we often discuss about that, but we should not forget that they are a very important partner in healthcare also. Thank you.
Actually, healthcare insurance company is the most important because they have the money. I would start first by introducing healthcare system in Slovakia, just so that you understand healthcare system in Slovakia is free, which means it's not actually free, but everybody who earns money pays a certain amount of their income to the health insurance company. There are 3 insurance companies. One is owned by the government and 2 are private. Insurance company Dvovera has 30% market share. So it's always up to the patient or person to decide whether they're going to go for public or private. Over the past 2 days, here we heard a lot about safe medicine, about how important it is for the nurses to give patients the right drugs and the right combination of drugs. And from what I heard over these 2 days was that it is all the records are stored within one hospital, which means if you have a patient coming from a different, maybe different country or different GP, you wouldn't know about drug interactions or any other treatment the patient has. So with a health insurance company storing all these records about all their patients, which is about 1.5 million patients, so this takes electronic healthcare record on a national level, not on a hospital level, just so that you can scale about our safe medicine. So it's not about the hospital, it's about the country. Like we heard with the previous speaker as well, healthcare sector has several problems. We can name high costs, low efficiency, health risk, and frauds. I think I don't have to go into detail with all of these. I'm sure you're all aware of them. What is important when it comes to a health insurance company is that it's very regulated sector. The processes are very often set by the government, so the insurance companies don't have much choice of choosing between better or worse. There are certain procedures that they must do. So the only question is whether they will do it efficiently or not. So let me tell you how the process of prescription works in Slovakia today. If I'm a patient and I go to the doctor, they have a blank form and they prescribe drugs, either manually or those sophisticated ones use computers and they prescribe drugs. If I also see a specialist, not just my GP, the GP wouldn't know about other drugs or other treatments that I'm taking, so they wouldn't know if they just have to rely what I tell them. Maybe I'm just taking some vitamins, and they wouldn't, and I don't consider it as important for my health, but maybe they will prescribe drugs that would interact with the drugs. But I don't know. I'm not a doctor, and if they ask, I cannot tell them. And when the doctor prescribes drug, the only proof of validity is a stamp and signature of a doctor. With the prescription, I go to a pharmacy. I hand in the prescription, and the pharmacist just visually has to verify the stamp and the signature. And as you can imagine, it's impossible to know all the stamps and all the signatures. The staff in the pharmacy doesn't really have much choice. They most of the time just give me the drugs. What is important that in pharmacies, when they apply for reimbursement, they have to process all the prescriptions manually. Now it's where science fiction part comes in. It's about 50 million prescriptions per year that have to be processed manually. So at each pharmacy, they have to take all the prescriptions at the end of the month, type in all the details from the prescription, which is a name, person ID, the drugs prescribed. Everything has to be put in a system. And if you have a very skilled person working in a pharmacy, they can process 40 prescriptions per hour. So you can imagine how time-consuming this actually is. But they have to do it because they want money from the insurance company for drugs that are either fully or partially paid by the insurance. So at the end of the month, they will process all the prescriptions and send the data to the insurance company. But you can have their delayed of 4 to 6 weeks. So the pharmacy has to wait for its money. Then in an insurance company, they process all the prescriptions also manually, and they have to match. If they find a fraud, they don't pay. They don't pay the money to the pharmacy. So as a patient, I'm not very well informed. I'm not reliable, and and I can actually risk my own health if we keep continuing doing things like this. And just to sum up, just so that you see the process, how the process goes from a doctor to pharmacy, from pharmacy to the insurance company, and then it goes back to the pharmacy. So we heard about the bedside scanning and how important it is. So I would like to hand over to Mr. Veres, and he will tell you how we managed to sneak in GS1 standards in this reimbursement process.
Thank you. Good afternoon. Well, in April 2014, we adopted on the level of the board and after communication with our shareholder that we are not going to wait anymore for public, national, EU-funded e-health project, never ending and never coming. And on the contrary, we decided to introduce our own e-health private initiative, and we started with e-prescription. It was 1.5 years ago, and in the next few minutes I'm going to explain you how the scheme, how the process has changed, and also something about new value-added services regarding patient safety we introduced and made available for our policyholders and contractual doctors. It's important to say that in Slovakia, one more thing about regulation. It's important to say that in Slovakia, a pharmacist is not obliged to see all the prescription of the patient, nor the drug history. He is obliged only to process the data from the form the patient brought in the pharmacy. So we had to solve the problem and find some efficient way how to link together the data from the computer of the doctor and get them to the computer of the pharmacy in order to get online data about drug handover. So we asked GS1 for an idea, and at the end we used this unique global document identifier in order to be sure that there would be no mismatch with any consumer products, any document ID, either internal in our health insurance company or any other. So we have added this unique identifier to every prescription for our policyholder, and it's working in a very simple way. Once the doctor is prescribing a drug, there is a complete data set, complete prescription record is sent to the health insurance company. We get back to the software of the doctor this unique ID, which is printed in a form of barcode on the prescription form. And we also require that the software automatically checks possible drug interactions within our database. This is all functioning over internet, over secure web services, and it's absolutely online and instant. Next, the pharmacy just scans the ID, gets the prescription record from the health insurance company, and after the drug is sold, mostly sold to the patient, we get in a few seconds also information that this drug was sold, was handed over to the patient, and we can update the information in drug history and patient medical record. It's important to say that we share these medical records with doctors, and this is the first initiative in Slovakia that they really know what the treatment is and what the drugs are used. Of course, there is no need to manually retype all the data. That's a crazy thing, which is still in this era common in Slovakia. Not only the insurance company has real-time data, and of course we can do advanced analytics and big data analysis and very nice stuff about, but we can share the data. We can share the data, as I have already told, with all the doctors and of course patients, and so that we can increase the quality of the service of the healthcare service. Patients are treated in a more safer way. They can also save a lot of money because thanks to the SMS notifications we send them on every prescription, they can choose alternatives or generics just to save their co-payments. And of course there are notifications also about possible drug interactions or the prescription validity, useful information for patient. If there is something not just to tell, right, they can use our mobile app and very easily claim that I'm in Croatia sunbathing and I'm not in the pharmacy getting any drugs from the pharmacy, so something is not going okay, and there is some fraud just happening. The scheme a little bit changed. Of course, there is a patient everywhere in the communication involved. What I would like to stress is that we realized this project within 6 months with very small budget, less than €1 million for complete development, software development, education, PR, and of course integration into all relevant softwares which are hospitals, doctors, clinics or pharmacies in Slovakia using, and of course including some, let's say, free license for them to use this product, so they don't have any additional expenses regarding this project. Now the penetration is nearly 40%. 40% of healthcare providers in Slovakia are connected in this virtual IT and of course legal or contractual infrastructure. It's on a voluntary basis, so I think the numbers are quite good, but we want to have at least 80-90% penetration within another 1 year. It's not in the presentation, but I would like to say that at the moment we are the only health insurance company in Slovakia which records decrease in drug costs this year, and this is mostly thanks to this project. Others are going up and they spend more and more money on drugs and they don't have any control over this, over consumption, duplicities, frauds and all of that. We are, of course, trying to increase the scope of the project and to share more and more information, and we have made, for example, all this data available to the rescue service on their tablets. So there's another one good point for the patient that it's not anonymous one who meet some ambulance and rescue stuff, but they can get instant data about the patient, not only about drugs, but all about the treatment, about some special information about doctors. So it's developing, but I would like to finish this presentation with some simple recommendations to all whom it may concern. based on our long-term experience and, of course, this project as well. First is go digital whenever, wherever possible. The second, use standards, preferably GS1, but I don't mean only this one. Standards in communication, standards in interfaces, standards in protocols. And the third one, keep it simple and client-oriented. Deliver value, deliver the best possible value for your client, and you will be successful. Thank you for attention.